Welcome. This is a case study presented to you by Aeron, Lloyd, Omas-as, and Katrina, and Venancio, interns from the Davao Medical School Foundation Histopathology Department. This case is entitled, A 67-year-old Man with Community-Acquired Pneumonia. Now, let us proceed to the patient history. A 67-year-old man was admitted to DMSF Hospital. The history of patient illness presents multiple stroke in the year 2015 with slurring of speech, right side facial weakness. 2 weeks prior to admission, the patient was noted to have aspiration episodes, occasionally with fluid. The patient has productive cough with minimal sputum, no fever, no chest pain. He was a smoker by having 6 packs a year. Patient was on routine checkup and was advised admission, hence admitted. The physician then ordered the series of tests: electrolytes, troponin I, glucose, lipid profile, coagulation test, complete blood count, creatinine, chest radiograph, diagnostic thoracentesis, and a gram stain. The initial diagnosis of the attending physician was pleural effusion, hypertension, and hyponatremia. This was due to the laboratory tests performed. It was also noted that the physician ordered a chest X-ray. Then, the physician proceeded to the diagnostic procedure, which was thoracentesis. The specimen was a pleural fluid, which consists of a yellow fluid approximately measuring 500 ml. Now, let us proceed to the laboratory results. For the electrolytes, the sodium and potassium seemed to be normal, also with other tests such as the troponin, creatinine, and the glucose, while the blood urea nitrogen level is decreased. Decreased levels of BUN can be due to significant liver damage or disease that inhibits the production of urea. Low BUN could also be caused by low blood flow to the kidneys caused by dehydration or heart failure. The other laboratory test results also shows normal on its lipid profile for the cholesterol, HDL, LDL, and TAG. For the coagulation tests, the prothrombin time and the APTT is normal within range. Also in their complete blood count, the hemoglobin, hematocrit, RBC count, MCV, MCH, MCHC, platelet, total leukocyte count, the lymphocyte, monocyte, and the basophil seem to be normal. However, the value of the neutrophil is quite high. This tells us that there could be a causative agent such as bacteria that yields the disease of the patient. In the histopathology section, the smear consists of a fibrin mixed with occasional lymphocytes, plasma cells, and histiocytes, and segmented neutrophils. Therefore, the clinical diagnosis was community-acquired pneumonia. Community-acquired bacterial pneumonia. Pleural effusions are a common findings in patients with pneumonia. More than 40% of patients with bacterial pneumonia and 60% of patients with pneumococcal pneumonia develop parapneumonic effusions. While treatment with antibiotics lead to resolution in most patients, some patients develop a more fibrinous reaction, with the presence of a frank pus in the most severe cases. The latter is referred to as an empyema or empyema thoracis. Parapneumonic pleural effusions are classified into 3 broad groups, based on fluid characteristics, which in turn provides a reflection on both the severity and natural history of the pleural effusion. Complicated parapneumonic effusions occur as a result of bacterial invasion into the pleural space that leads to an increased number of neutrophils, decreased glucose, pleural fluid acidosis, and an elevated lactic dehydrogenase concentration. These effusions often are sterile because bacteria are usually cleared rapidly from the pleural space. The fluid is typically cloudy and is classified as complicated because it requires drainage for resolution.